Good morning, everybody. We begin with the August edition of the IHRS DM-DNB teaching program. I am Dr. Ashish Nabar, Joint Secretary of the IHRS. The committee of the IHRS, the executive committee, entrusted this thing to me of conducting a monthly IHRS DM-DNB teaching program. And thanks to the inspiration from our president, Dr. Yash Lokhandwala, we have been able to do this program with a good regularity. And thanks, of course, to the faculty from different academic as well as private institutes doing a good EP work all over India. All the faculty, you have always been willing to come up with some theme and present what is best suited for the DM-DNB. That has been the focus. So the program is not meant to be for electrophysiologists. So therefore it's been tailored and constructed so that the DM-DNBs have some benefit in terms of either their exit exams or feeling a bit interested to pursue EP as a career later on. But the focus presently is that it helps their regular becoming of an all-round cardiologist. And further, we have always been lucky to have the moderators from similarly acclaimed institutes who IHRS faculty by and large, who have been again very willing to oblige us to immediately agree to us and come on the program and share their thoughts, remarks, discussions, enriching the discussion. So I do not want to stand too much between the program and you. This time I have put it up as coming from the melting pot of Mumbai. So that actually means that we have a mix of presenting faculty from one from the Department of Cardiology at KEM Hospital and LTMGH Sion Hospital from Mumbai, two leading academic institutes from Mumbai. And we have two faculty who are practicing electrophysiologists. So I think you will enjoy them. Since this time I kind of play the host and the master of ceremony. So let me say Dr. Dheeraj is from KEM Hospital. Dr. Abhinav is from LTMG Hospital in Sion. Dr. Samir Rane and Dr. Saurabh Deshpande are already practicing electrophysiologists. So welcome to all four of you. This time we also have as moderators, usually I try to say, request people from different zones so that we have a good mix of ideas coming from different corners of India. So this time Dr. Vivek Chaturvedi from Delhi and Dr. Kumar Narayanan from Hyderabad have agreed to be the moderators, and I'm sure they will share their thoughts. So I think let's begin. The program has, I think, a mix of both devices and some EP concepts, and should turn out to be useful. Sure. So Dheeraj, I think you can start the first presentation. My only request to all the attendees is to keep themselves on mute so that we have least disturbance through the program. You can put your questions in the chat box, and the other moderator can always look through them and put up for discussion. Dheeraj, you can start with your presentation.
Okay. Sir, can you see my slides?
Yes, very much.
Okay. Good morning, everyone. At the outset, I would like to thank the President of IHRS, Dr. Yash Lokhandwala, and Dr. Nabar, sir, who's in charge of the academics here, for this wonderful teaching program. And I look forward to it every once in a month when it is there on Sundays, because I gain a lot of knowledge and I go home and read a lot after that. So it's indeed a great opportunity, not only for DM, DNB students, but also people who are in between, who are not yet electrophysiologists, who are training hard to get there, who are trying to understand the concepts. Now, today's talk is a very interesting one. It is based on appropriateness of ICD therapy. We will learn it case by case, because in a didactic form, it can be extremely boring. So we all know that the number of ACSs and number of infarcts are increasing day by day, and as a result, the number of patients who are getting ICD implants are also increasing. Although ICD implant is a job which needs skill, but understanding how to program and understanding and interpreting device therapies needs even more skill. What complicates the matter here is the lack of understanding among some of the physicians about how the device algorithm works. And second thing is an inter-company differences between how the algorithms differ. So we start with some basic concepts. So when a patient with an implanted ICT or a CRTT comes to you directly, it is very important to put all the things in the all the parts of the puzzle in order to complete the picture. So you have to look through the papers to understand what was the indication of the implant, what was the drug regimen the patient was taking, what is the change in disease substrate, whether the patient's disease has progressed or not, and of course whether there is a new disease which has come in, whether there's a new ischemia, whether there's whatever. You have to look at a 12-lead ECG because devices often provide you with a 1-lead ECG data. 12-lead ECG is invaluable. You can look through the device and program settings, battery status, and the EGMs of the event. Looking at chest X-ray and fluoroscopy are very important because that will give you a hint about device malfunction. And finally, not only all this, but looking at blood electrolytes, because often enough hyperkalemia can lead to very tall T waves, sometimes which might be oversensed. Thyroid status is also important. Going on to this basic slide, in which we will delve into what does the device see. So remember the device, we are looking at a single chamber ICT here, in which there is a tip and the ring. The tip and the ring are well embedded into the myocardium. There's a coil which is supposed to be there in the right ventricle, and then there's a lead and a can. Now, the device has got two fiducial, sensing apparatuses. One is the tip and one is the electrical difference between the tip and the ring, that is near the tip of the lead. This is called as the near field EGM. Near field as in very close to the ventricular myocardium. And why is this important? This generally creates a bipolarish sort of an EGM, and it is very good for timing of events and early detection of events. The far field EGM is often between the coil and the ICD can. This helps in looking at the morphological aspects. As you know, the coil and the can are far away, therefore they engulf a larger area. A larger area means a sum of depolarization vectors that you can look at. It's like a single surface lead ECG. Therefore, a far field EGM is important for looking at the morphology. And the third important thing that is to be looked for is what does the device label each and every ventricular event as, whether it is a sensed event, whether it's a tachycardia, whether it's a fibrillation. So this is called the marker channel, and below it are given very in little small letters, small numbers, the cycle length between the two sensed events. Now this on the right hand side is even more interesting. How does the device label each and every sensed event? Now, it is very important that the device understands that after a ventricular sensed event, within the first 120 milliseconds, it is generally any event that you get is often a blanking, often non-physiological, and therefore it goes into the blanking zone. After that, from 120 milliseconds to 300 milliseconds, if there is any event which is seen, which is sensed, then it is going into the ventricular fibrillation zone. And of course, these zones can be programmed. From 300 to maybe 450 or 500, you can have any event in the ventricular tachycardia zone. And beyond, a rate of 100, that is 600 milliseconds, it's a sensed zone, ventricular sensed zone. So you can program 3 zones, you can program 2 zones, how you program. And there is a threshold below which the device starts spacing, whether it is a 40 beats per minute or 50 beats per minute, that is the bradycardia. So you have a bradycardia zone, you have a sinus zone, you can have a VT zone, you can have a fast VT zone, and you can have a VEF zone. Why do we have different zones? Because your aggressiveness of therapy would be depending upon the kind of zone. So a fast VT zone, fast VT is more likely to cause syncope than a VT. So you need to be a little more aggressive than a VT zone in a fast VT zone. And VF, you need to be very aggressive because it can cause syncope very quickly. So that's why we have these zones, and that is why this is how the device interprets any electrical activity in the ventricle and times any electrical activity. Going on to the next, there are 4 steps in any ICD. It senses an electrical event. This sensing must be accurate. We will look at what are the parameters that the device has in its mind when it senses. Then we look at the detection. What does detection entail? So what basically we looked at the rates. Rates are important. Rate cutoffs to decide whether it's a VT, FVT, or VF, or VT, VT1, VT2, or VF, depending upon the company. And of course, the number of intervals that the device detects these events for. Then the device has an algorithm to distinguish whether whatever it has detected is an SVT or a VT. And if it is an SVT, it does not deliver therapy, but records it for future reference. If it is a VT, then it goes on to deliver therapy in the form of anti-tachycardia pacing, that is 20 to 30 millisecond cycle length lesser than the VT. Of course, we decide the therapy. So there are 2 types of anti-tachycardia pacing. We have burst pacing and we have ramp pacing. In ramp pacing, each and every progressive paced beat is at a cycle length which is shorter. So cycle length becomes shorter and shorter and shorter. We'll have an example to show that. And finally, if anti-tachycardia pacing doesn't work, there will be a shock delivery. Okay, so these are the 4 steps. Now, what is important is sensing. As I told you, sensing is very important for the devices. When a device senses a signal, it looks at the signal's amplitude and it looks at the signal's frequency. Why is it important to look at the 2 together? Sometimes these more than 100 are supraphysiological frequencies. Intracardiac events don't have frequencies more than 100 hertz. And if a device senses something which is beyond this range, it immediately knows that it is something related to a noise. It is something related to an electromyocardial interference, EM interference, or it's a myopotential, basically some kind of tremor or the muscle potential. And therefore, it does not deliver therapy. It immediately knows that it is a non-physiological signal. Again, on this end of the spectrum, anything which is less than 2 hertz is generally thought of as a non-physiological signal. Often we know, or a physiological signal which we don't want to treat, like a T wave or a far field R wave. Correct? So, and so is the case with amplitude. So anything which is amplitude is less than 3 millivolts and is not falling into this, then we are thinking of non-physiological signals. This is very important for the device to not give therapies for non-physiological or physiological signals without any which we don't want to treat. Now, what is inappropriate therapy? Appropriate therapy is when the device treats VT or VF. Inappropriate therapy is when the device actually treats sinus tachycardia, atrial fibrillation, atrial tachycardia, an oversensed event, special reference to T wave oversensing that we will go through, some kind of a lead malfunction that creates a non-physiological signal which is falling into that range less than 100 hertz. And finally, electromagnetic interference. Especially, we know that high voltage people working in high voltage occupation, that can create an electromagnetic wave in the leads, and that may lead to oversensing, and that may lead to therapy. So it's also important to look at what professions the people are working in, especially drilling and high voltage patients involved in high voltage areas are more susceptible to inappropriate therapy. Now, what is ventricular oversensing? Oversensing is non-physiological sensing. It can be non-cyclical or cyclical. If it is happening in various different cycles in a pattern, then it's cyclical. If it is non-cyclical, it could be intra or extracardiac, generally extracardiac. Extracardiac like myopotentials, non-physiologic like lead connector issues or electromagnetic interference. Intracardiac obviously can be lead failure. Cyclical, if you are sensing more than one event per cycle, it is generally a non-physiologic cycle like a lead failure. And if it is only one oversense event per cycle, it could be double counting of R waves or P or T oversensing. So now this is an example that I found to be very interesting. Here, if you see, you are seeing that there is a near field signal, there's another signal, there's a near field signal, there's another signal. This second signal is coming at a little variation of 285 to 297 to 297. It's almost fixed. And the device interprets it as a tachycardia event and delivers a shock. Now, what is this event? What is this signal? This is nothing but a T wave, a tallish T wave that the device is sensing. Why is it so? See, in ICDs, we don't have fixed detection. We have a detection which detection threshold which is starting high just after the QRS and then decays. This is purposely done because just after the QRS, it is likely that there is going to be a T wave and we miss the T wave. Sometimes the QTC might be such and the T wave amplitude is such that it is getting detected by the device and you get a closely spaced event being marked at a device and given therapy. So what programming changes we did was, rather than 0 milliseconds at the start of the decay, you delay it by 60 milliseconds. That means the fence is over the height that the dog can jump, and therefore it misses the T wave and you do not detect the T wave. And bingo, voila, after you reprogram it, the T waves are not being detected by the device, and this is how one can abort a therapy. Now, this may be decay may be programmable in some devices, may not be programmable in some other devices, but modern devices have T wave sensing algorithms which take into consideration, as I showed you earlier, the frequency and the amplitude both together, which is fed into the algorithm, and therefore it can recognize T waves very successfully. There is another thing that the modern devices have, how closely matched this abnormal signal is to the preceding QRS, and then there is a gap. So T wave has a particular way in which it occurs. It occurs at a fixed duration after the QRS, and then there's a longer duration. So if it is like that, then often T wave oversensing is avoided. Now, this is how the algorithm of a dual chamber ICD works. The first step that a dual chamber ICD does whenever it senses a high rate event is to compare what is happening at an atrial channel and what is happening at a ventricular channel. And if the ventricular rate of event is higher than the atrial rate, it knows that the problem lies in the ventricular chamber, and therefore it classifies it as VT and delivers the therapy. If the atrial rate is higher than the ventricular rate, it is likely to be an atrial arrhythmia which is getting conducted at a variable rate to the ventricles. However, it is still possible to have a slower VT down below and an atrial tachycardia above. So what it does is it looks at the interval stability of the atrium, and it also it looks at AV association. So if two-way atrial waves and then there is a QRS after a certain AV interdelay, then it thinks about it as atrial arrhythmia with conduction, and therefore does not deliver therapy. Also, what it loses in addition is a morphology map. See, the device stores the morphology of the far field and near field during sinus rhythm. Whenever there is a tachycardia, it matches the morphology of the far field and near field during this tachycardia and sees whether this matches to the sinus rhythm. If it is similar to sinus rhythm, it is more likely that there is an atrial arrhythmia which is getting conducted. Whereas if the morphology completely changes, then we know that there is a problem, and this is actually a ventricular tachycardia because the morphology has changed. And therefore, it then decides whether it's a VT or an SVT and decides to deliver therapy or without therapy. For single chamber ICDs, it looks at only three things. One is that VTs, so there are three suppositions. VTs have abrupt onset, SVTs may or may not have abrupt onset, but sinus tachycardia has a gradual onset. So if there is a sudden onset, it thinks of it as a VT. But if there's a gradual onset, the device knows that this is a sinus arrhythmia, so it does not provide any therapy. Morphology changes in VT, so the device can understand the morphology by comparing to the sinus template that it has stored. And finally, it is important to understand that whether VTs generally are having stable intervals. Just at the onset, there might be a bit of variation, and towards the end, there might be a bit of variation. But VTs have stability, means the cycle length of VT is fixed and it varies within 40 milliseconds. That is the other criteria that it looks at. One very interesting thing is sinus detection history, sinus interval history. Within its detection, if more than two beats come, which are at a cycle length which is consistent with what is sinus, then the device thinks of it as an SVT, classifies it as SVT. Why is it so? When you have an atrial fibrillation, you have widely varying RR. And some of the RRs would fall in the sinus detection limit. And if that is so, between the detection, it knows that it is probably an SVT with a very varying RR, and that is how it's going to abort the therapy.
Dheeraj, you have to be a little quick.
Yes, and now we are talking about the templates. Templates are very simple. They are based on broken into blocks of 4, far field, and in the above, this is the sinus template, the above part, and the lower part is the during tachycardia template. If they match, it's a 100% match, it's an SVT. If they don't match, you see the test template has very tall C, and so does this test template, and the sinus template have very tall C. The D, negative D, is much taller in what you call test as compared to sinus, and the A, the first deflection, is much taller in test as compared to sinus. It's only a 60% match. The device classifies it as VT. Now, the first case is 62-year-old male patient implanted with an ICD. Device was replaced in 2018, and patient was admitted in the hospital after getting multiple episodes of shock. Now, what is this? What does this? We looked at the EGM. We saw that this patient during the event is having a variable cycle length. It's very clear that you can see 340, 383, 305, 316, 285. So it's variable cycle length, and the device detects it as a tachycardia and some of it as ventricular fibrillation zone. You can see how the device is detecting it. And of course, you can see the cycle length variation. And the device provides an ATP and followed by a shock. Okay. Now, what is important that you must understand is all these things that I said only work in VT zone. They don't work in VF zone. And this patient had multiple episodes of irregularity in the VF zone. So because of which the device gave the therapy. So we looked at the baseline programming. We looked at the VF zone being set at 214. That is coming out to be a cycle length of 280. And we looked at discriminators. All the discriminators were disabled. So sudden onset and interval stability. Okay, and detection was only for 12 for VF and 20 for VT. So what is the conclusion? This is nothing but an atrial fibrillation with a fast ventricular rate. It is misclassified as ventricular fibrillation, and that is why the device delivered therapy. What can you do? You can reprogram it. You can reprogram the VF zone to 230 or above in this case, and also so that the stability and the onset parameters can be switched on and they can work. And therefore, you can avoid therapies. Of course, number of detection intervals can also be increased. So this is common. You can get atrial fibrillation misclassified as ventricular fibrillation. There's another case, 53-year-old male patient implanted with CRT-D, ejection fraction of 30%, never had any episode. 2 years down the line, I presented to you with multiple shocks. Now you see this EGM, and you can easily recognize that in the ventricular channel, something abnormal is happening. So A sense, V sense, A sense, V sense, and then you see multiple high frequency signals, often more than one per cycle length. If you remember, more than one per cycle length, high frequency signals, only there in ventricular channel, they are nothing but lead abnormality, lead related noise, and that noise has been classified as VFib, and a shock has been delivered. Now, this patient needed a lead revision and patient was fine. Now, what is important is how would you distinguish it with electromagnetic interference? If you have two leads, you would get electromagnetic interference in both the leads, atrial as well as ventricular channel, which is high frequency. But this is not happening. And of course, this patient did not work in any high voltage setting. Okay. The third case is a patient who is hypertensive, diabetic, anteroval MI, had a CRT-D and IPG replacement in 2019, comes with an interrogation as follows, says that he has received a couple of shocks. We look at the EGM. This is the basic parameters that we see, and we see the detection zones 170, 200, more than 200 beats for VF zone, and VT between 150 and 200. Now we look at the EGM. What can you observe? The EGM in the initial part has a cycle length of 630, 640, 640, 480. Suddenly there is an event wherein which the cycle length changes from 350, 300, 300, 310, 310, and now it is almost stable. And you look at the atrial EGM, atrial rates are fixed at 690. So V is greater than A, number one. Number two, there is an abrupt onset, right from 640, 480 to 350. And final nail in the coffin is obviously there is a stability in the cycle. The device then starts giving ATP. So this is the burst ATP at a constant cycle length. It gives two burst ATPs. If you remember the device programming, we had two burst ATPs and then two ramp ATPs. And just after the ramp ATP, the tachycardia accelerates. So it doesn't give the second ramp ATP, it goes into the VF zone, and therefore the device delivers shock. So sometimes ATPs may make the device, make the arrhythmia more aggressive. It's like, what do you call, so that can lead to an incremental therapy. So this is an appropriate therapy. What we did is increase the dose of amiodarone, we increase the dose of beta blockers, and the patient is doing well. Finally, what do you need to take home as a message? You, after looking at this, you decide whether the therapy was appropriate or inappropriate. If it was inappropriate, can you reprogram or not? Can you, if there's a lead issue, you revise the lead. If there is a drug therapy that you can increase, you can change the drug therapy. And if the battery is depleted, you can change the IPG. This is important to understand. When you are getting more inappropriate therapies and you are getting less appropriate therapies, you program all the discriminators more aggressively, and you are less likely to give therapy. If suppose with the discriminators on, you are missing certain appropriate episodes, you are programming in a way which is basically less template match, and your number of interval detection you can decrease. You are making the LCD more aggressive. So you can always tweak depending upon the clinical scenario. Okay. Thank you.
Thanks, Dheeraj. Of course, you can present only so much in the given time, and wonderful job. Vivek, you want to have some discussion with Dheeraj and clarify certain aspects?
I think for the first two cases, I think I am supposed to.
Yeah, sorry, Kumar, please. My mistake. Yeah, please.
No problem. So very good presentation, Dr. Dheeraj. You covered some of the fundamentals of how to do this. So I think to summarize, we can bring out two important points. The first thing, I think, from the point of view of basics is that ICD sensing is more challenging than pacemaker sensing. That's one important message to get across. Because in pacemaker sensing, it doesn't have to detect tachyarrhythmias. So in ICD sensing, the problem is during VT or VF, the electrograms can be less in amplitude. They can also be very disorganized. So you have to be sensitive enough to detect that, but at the same time, you have to prevent oversensing during normal times. So this is the crux of the challenge as far as ICD sensing is concerned. So as you rightly showed, using the amplitude frequency content by using the decay delay function, which you showed an important one where the sensing window progressively comes down after the QRS. All of these features the ICD uses to try and avoid oversensing while at the same time having reliable sensing for VF. And the other important point is in distinguishing the true ventricular arrhythmia from other arrhythmia. So any shock which is delivered for other than VT or VF is an inappropriate shock, which we don't want to do. And it's one of the major problems with ICDs, especially in young and active patients who are more likely to have sinus tachycardia, who are more likely to have other kinds of arrhythmias. And they're also very physically active. So the chances over a period of time for their lead damage or lead fracture to happen, lead insulation issues to happen is also more. So one thing, one quick point, which probably we can discuss, and you had already commented, in your case number 1, where you had said we are going to increase the number of intervals or, raise the bar for the VF zone in order to avoid inappropriate shocks. And that is a factor which is becoming more and more common now, especially after a landmark trial called the MADIT RIT, which showed that for primary prevention candidates, so primary prevention candidates are those who haven't had an arrhythmia as yet. You are implanting an ICD based on certain risk factors that they are potentially at risk for ventricular arrhythmia. So for those candidates, setting a higher bar, such as setting a high rate cutoff for the VF zone or increasing the number of intervals to detect, is valuable in reducing both unnecessary shocks for non-sustained ventricular arrhythmias. So not only do we want to avoid inappropriate shocks, but also for self-terminating arrhythmias. Even if there is a VF which could spontaneously terminate within a few seconds, we don't want to shock. So from both points of view, such kind of a lenient programming has been now proven to reduce inappropriate shocks, and more importantly, it reduces mortality. That's important to emphasize because both appropriate shocks and inappropriate shocks tend to increase mortality in the long run. So I think that's an important point brought out by your case number 1. And again, in your case number 2, where you showed the issue of lead noise. So 2 important learning points from it are: 1, to be able to look at actual electrograms of the event, which is very important because at a glance you can see that those signals are clearly non-physiological, right? And then secondly, the importance there, I think in your displayed electrograms, the far field electrograms were not there. It was atrial and ventricular. But the importance of comparing near field with far field EGM. So if sometimes, you can see the noise restricted depending on where the lead problem is, restricted to near field EGMs, and you may not see it in the far field EGM. So again, you can make out that there is some kind of a non-physiological noise going on. So I think these are some of the learning points which you can derive from your illustrative cases. And lastly, the importance of always keeping clinical details in mind. For example, in your case 1, how do you decide whether I can safely raise the bar for VF sensing? That depends on the details of the patient, what was the indication for implantation, and also the symptoms during the event. Did the patient almost get, syncopal during an episode, or has the patient had very rapid VTs in that zone before, which has caused hemodynamic compromise? So all of these details are important before you can decide whether I can safely raise the bar for therapy. So I think these few points I just wanted to get across.
Sir, may I ask a question here?
Sure, absolutely. Yeah.
Okay, so I have read that the Achilles heel for ICD detection, especially single chamber ICD detection, is an atrial tachycardia with a bundle branch aberrancy, which is a constant rate. Now, in a subset of patients where we expect atrial arrhythmias and ventricular arrhythmias to be in equal proportion, like an HCM or like an Epstein's, can we for a VT, Epstein with a VT, can we implant a dual chamber, because it will give you a chamber of onset added to your algorithm, and conduction also added to your algorithm, and we maybe help to distinguish therapies better, because generally I've been taught that modern single chambers are just as good as dual chamber ICDs, but which subset of population are you going to go ahead? I know that pacing, if the patient has pacing indication, yes, then dual chamber ICD makes sense. And in fact, then you can go to the extreme of putting an DF1 lead and putting a defibrillator lead and a maybe conduction system pacing lead differently. But in a non-pacing indication, where would you put a dual coil and a dual chamber ICD?
So my personal take on this is that, as you rightly said, we still don't have solid evidence to show that as far as discrimination and reducing inappropriate shocks are concerned, the dual chamber ICDs do better than single chamber ICDs. There are some, registry and observational studies which have suggested that, but we lack solid evidence in that term. So as you rightly said, presently, the main indication for dual chamber AICD is an anticipated present or anticipated need for pacing in the future. But your point is well taken, that if you have a substrate where you think that there could be a very high frequency of atrial arrhythmias, logically, it sounds kind of tempting to think that a dual chamber would discriminate better. But again, evidence to support this is lacking. The particular scenario which you're saying, that you would have, an atrial arrhythmia with a broader QRS aberrant conduction, and therefore, what happens is that the morphology template could potentially fail in those cases. Otherwise, even a single chamber ICD with current morphology templates, they do a pretty decent job, even without an atrial lead, in distinguishing SVTs from VTs. So most of the time that should take care. Probably the scenario which you described doesn't occur commonly enough to demonstrate, an incremental benefit of the dual chamber ICD. But it's a point well taken that in some patients you could individualize your decision making. That if you do have this kind of a unique scenario, you could think of putting in an atrial lead as well.
May I make another point?
Dheeraj, I think we should move, because a very, very interesting discussion, obviously, and it's not a customary statement. It really was a good presentation, but of course we are bound by the time, we will share more thoughts of Kumar in the next presentation. So can I request Abhinav to start his presentation?
Good job.
He also has something interesting related to the device, I guess. Yeah, Abhinav, please.
Good morning, sir. Good morning, respected panelists and everyone.
Okay, your slides are seen, Abhinav. You can start.
So before I begin, I would like to thank respected Dr. Yash Lokhandwala sir and Dr. Nabar sir to give me this kind opportunity to present this case in the IHRS program.
So just before you start, Dr. Abhinav has been trained at the Jaideva Institute in Bangalore. He has been with us at KEM for a while, and now he's at Sion Hospital. So I think that's very interesting, and I'm sure he'll make a good job of this presentation. Abhinav.
Yes, sir. So I would also like to thank the entire Jaideva EP team for introducing me to the complex and beautiful world of EP. So my case, this was a 68-year-old gentleman who presented to the Pacemaker clinic. This patient had one episode of syncope 2 days ago. Also, he was feeling episodes of intermittent pre-syncope since the past 2 weeks. These episodes were similar to the ones he used to get before the implantation of pacemaker. So we did the routine examination. His pulse rate was around 30 beats per minute. He was normotensive. And then his ECG was taken, which revealed failure to capture, presence of pacemaker spikes, and the patient had reverted to complete heart block with a ventricular escape rate of 33 beats per minute. So because of the history of syncope and failure to capture on the ECG, he was immediately taken to the interrogation room. However, the pacemaker interrogation revealed a capture threshold of less than 0.5 volt, an impedance of 587 volt, and a remaining longevity of 1 to 1.25 years. So this was essentially a normal pacemaker interrogation. So to summarize, 68-year-old gentleman, status post pacemaker implantation in 1994, presented with syncope, ECG showed non-capture and a normal pacemaker interrogation. So before we proceed further, let's take a moment to define this problem. First, this patient had failure to pace the appropriate chamber. This can either be due to failure of output or failure of capture. As we can see on the ECG, there were presence of pacemaker spikes, but no capture. So this was a case of non-capture. Secondly, this was an intermittent problem. Since taking the ECG and getting shifted to the interrogation room, the patient had somehow reverted back to a normal interrogation. So an intermittent problem may be due to problem with electrode endocardial interface. This is more common in the perioperative period or when the stimulation threshold is close to the pacing threshold. If the problem is not at the electrode endocardial interface, then it can be with the lead connector system. Thirdly, if we look at the ECG, the pacemaker spikes are occurring regularly without any interruption from the intrinsic beat. This means that the intrinsic ventricular beats are undersensed. Now, causes of undersensing, they can be divided into three categories. The beats may be occurring during the refractory period, which may be seen in the initial part of the ECG. However, as we progress towards the end, we see that even when the intrinsic beats are coming beyond the refractory period, they are not sensed. The second may be due to inappropriate amplitude or slew rate of the intrinsic beat. And the third reason of undersensing is attenuation of signal by the electric dysfunction of the lead or the pulse generator. A malfunctioning pulse generator can be caused by component failure in the electric circuitry or a defective reed switch which remains in the closed position. In both these cases, this will result in asynchronous pacing. Very importantly, in the analysis of ECG undersensing, oversensing producing asynchronous mode pacing due to interference should always be excluded first as the possible cause. So after getting a normal interrogation, since this patient had a history of syncope, we increased the pacing voltage to 5 volt to ensure ventricular capture, and then the patient was shifted to the cath lab for a temporary pacemaker insertion. Next, we went through the earlier papers of this patient. He had undergone a single chamber pacemaker insertion in 1994. This was a unipolar lead. He underwent battery replacement twice, once in 2007, the other time in 2014. During the last pulse generator change, the threshold had shown an increase to 1.5 volt. However, since this was a chronic threshold, it was accepted. During the last interrogation, the impedance was 284 ohms. Thus, we noticed that even though the impedance values were in normal range, it had actually increased by more than 100%. After taking this patient on table and inserting the temporary sheath, we performed provocative maneuvers, which I'll be discussing subsequently. This showed a drop in impedance to around 312 ohms. During the time of provocative maneuvers, the lead showed presence of oversensing artifacts. These artifacts were intermittent, high frequency, non-cyclical, non-physiologic. As you can see, the intervals were in VF zone with post-pacing oversensing. There was a variability of amplitude, and these were reproducible by manipulating the region. thus giving us a diagnosis of lead fracture. Next, fluoroscopy of this patient was done, which showed presence of fracture of the pacemaker lead at the subclavian insertion site. The tip of the lid was inserted beyond the set screw. So a connection problem may be diagnosed if the set screw mark is within 0.165 from the tip of the pin. Normally, this distance will be more than 0.33 centimeter. So for management, this patient was planned for pulse generator with lead replacement. During the time of lead replacement, the leads were again interrogated. They showed intermittent loss of capture during pacing at a high output when they were manipulated in the pocket. He subsequently underwent pulse generator with lead replacement via axillary approach. At 1 month of follow-up, the patient was completely asymptomatic with no repeat episode of syncope. Next, we'll come to the discussion part where I'll be discussing approach to a patient with non-capture, lead impedance in the diagnosis of lead failure, and subclavian crush syndrome. In a patient with non-capture, the differential diagnosis can be narrowed down with the help of these 3 points: the time of onset, the capture threshold, and lead impedance. So, non-capture means delivery of a pacing spike that does not result either in P wave or a QRS complex. After ruling out pseudo malfunction, the search for etiology may be directed to individual components of the entire circuit. These may be pocket issues, pulse generator issues, a connector problem, or lead issues. Now, pocket issues are particularly important in unipolar pacemaker, which was the case with our patient. For example, a unipolar pacemaker will not pace till it is placed in the pocket, or presence of air coating, for example, in subcutaneous emphysema in the pocket, may be responsible for loss of anodal contact in case of unipolar pacing. So in such cases, you can press down the pacemaker so that it comes in contact with the muscle and you will regain pacing. Pulse generator problem can usually be detected by interrogation of the device. A connector problem usually occurs in the perioperative period. However, in a study by Swerdler et al., they showed that this can occur up to 200 days after implant. So what they showed was 11% showed a rise in impedance within first 30 days, 32% within 90 days, whereas 46% can show a rise in impedance due to a connector problem up to 180 days. Now, lead issues, they can be further divided into lead damage, dislodgement, or elevated capture threshold. The differential diagnosis in a patient with non-capture is also helped by the time of onset of non-capture in relation to implantation of the device and the lead system. So immediately after the implantation of pacemaker, the issues that may be encountered are highlighted in purple here. Now, lead issues can again be divided according to etiology. For example, a lead damage may be due to a conductor fracture, which will result in rise of impedance, or an insulation failure, which will result in a decrease in impedance. Lead dislodgement may be micro or macro, or it may be due to perforation of the thin-walled RV, especially in the leads which are placed at the apex. Now, elevated capture threshold may be due to a problem at the electrode tissue interface or due to a systemic problem. Examples of electrode tissue interface include lead maturation or damage due to an exogenous source, for example, electrocautery or defibrillation. A systemic cause, for example, progression of the underlying disease, inferior wall MI in which the lead is placed in the zone of infarct, metabolic causes like metabolic acidosis or alkalosis, electrolyte imbalances like hyperkalemia or drugs may lead to elevated capture threshold. Next, we come to provocative testing, which help with the diagnosis in this patient. Now, provocative testing consists of evaluation of pectoral muscle and the integrity of the subcutaneous part of the lead connector system. The myopotentials by the pectoral muscle can result in inhibition of pacing. Also, it may lead to reversion to asynchronous interference mode pacing. The provocation method for the pectoral muscle can be performed by sustained isometric pushing. The other method is hyperadduction of the arm ipsilateral to the pulse generator, and we try to reach as far as possible around the chest, leading to contraction of the pectoralis major muscle. The lead connector system diagnosis can be due to manipulation in the subcutaneous part of the lead system, which is the most common area of fracture in the system. Now, this was the algorithm which was given by Swerdler et al. In utilizing the impedance change for the diagnosis of a conductor fracture versus a connection problem. So, if the occurrence is within 30 post-operative days with abrupt impedance rise and a gradual return to the baseline more than 45 days, then it is more likely a connection problem. However, if the abrupt impedance rise is associated with noise oversensing or a very high impedance, which is more than 10,000, then it is more likely a lead fracture. I'll also be discussing subclavian crush syndrome. So, subclavian crush occurs due to entrapment of lead between the first rib and the clavicle. The putative mechanism is soft tissue entrapment by the subclavius muscle. Now, this causes a static load at one point and repeated flexure or tension with stasis at one point may lead to damage of the lead. This may lead to either insulation breakage with a decrease in impedance or conductor fracture with increase in impedance. Although this is described more commonly in large complex lead, our patients showed this in the pacemaker leads. Now, this was a study by Atrial et al. In which they showed that subclavian puncture compared to axillary puncture is associated with an increased incidence of pneumothorax and an increased incidence of lead failure, both of which are statistically significant. A similar case was present in European Journal of Case Reports in Internal Medicine. However, this was a case of complete fracture of the lead with increased impedance, unlike our case in which day-to-day variation with impedance was seen and which was manifested with provocative maneuvers. Thank you.
Yeah, Kumar.
Yeah, again, a very illustrative case, illustrating some of the important principles of, troubleshooting pacemaker malfunction. So I think the few, again, important points which emerge from your case, one is a systematic approach. So as you rightly showed, whenever you have a lack of capture, the first thing which you're going to see is whether a pacing spike is present or not. So whenever a pacing spike is present, as in your case, then the issue of oversensing is ruled out, because, if the device was oversensing something, then it's not going to deliver a pacing spike. When you have a pacing spike, then you have to, look at other issues such as, whether there's an issue with the output, whether it's programming, whether there's a problem with the integrity of the lead or other connection issues. So as you have, nicely highlighted in this systematic approach. The second important point which you again highlighted is that as far as the connector issues are concerned, they are more likely to occur shortly after implantation, though some cases have also been shown to occur fairly delayed. But in a case like yours, where it is occurring several years after the last implant, whether it's a first or a PG change, then it's less likely to be a connector issue after such a long time. And again, an important point related to the subclavian crush, which you again mentioned already. If you make a very medial puncture right into what we call the classical subclavian puncture, it's theoretically more prone to a subclavian crush. And also for this reason, it is probably advisable to avoid double wiring as much as possible during the implantation. Sometimes, we are in a little bit of a difficulty with getting it, and there is a temptation to to quickly just wire the one axis which you got with two wires and proceed. Again, especially if you're doing a classical subclavian puncture and you're going to crowd two leads in a dual chamber close together, then you increase the risk of mechanical issues. So overall, a good case to illustrate the importance of looking at EGMs with the device and
Kumar, a
as
quick
well as
comment.
the ECG. Yeah.
Kumar, can you
go ahead.
offer a quick comment on different types of leads and their proneness to integrity issues? I mean, the pacing leads, the ICD leads, LV leads, something like that. Yeah.
Sure. So the issue with the pacing leads are structurally more simpler as compared to a ICD lead. So one of the things which you were pointing out, especially with respect to the impedance issue or the Z. One point which has been brought out in studies is that despite a lead fracture, sometimes your impedance values can look normal even during interrogation, and this is because of the intermittent make-break phenomenon, what we call, where the coils can be touching and coming apart. The ICD lead is more bulky, it's more complex, and especially in younger patients who are more physically active with more vigorous physical activity or arm movements, they are more prone to complications in the longer run as compared to the simpler pacemaker leads, which is why the call to implant an ICD, especially in a younger patient, has to be carefully taken. And now you have also the potential alternative of a subcutaneous ICD, though it's still very expensive in our context, where you may potentially try and avoid the issue of long-term mechanical damage with an ICD lead. With the pacemaker lead, this is we can say lesser chances, but again, in the long run, when you're having a lead existing more than 20-25 years, the chances of mechanical issues may come up with these leads as well. Any other point, Dr. Ashish, which you wanted to?
No, sure.
Yeah.
I mean, good discussion. So I think let's more from the interest of time rather than learning. Let's move on from bradycardia and pacing related issues to some tachyarrhythmias to give you a good flavor of today's program. So we have Dr. Samir Rane presenting about something about atrial fibrillation, and the next two sessions will be moderated by Dr. Vivek Chaturvedi. So I think Abhinav can stop sharing his screen and Samir can get on. Yeah, Samir.
Slides visible, right, sir?
Sure, perfectly visible. You're
Yes.
audible also. You can
Yes.
get started.
Good morning to my seniors and all my esteemed colleagues. I'm thankful to Ashish sir and the IHRS for giving me this opportunity. Today's talk is on acute conversion of atrial fibrillation, the PIP-VIP approach. So abbreviations used during this presentation: AF for atrial fibrillation, antiarrhythmic drugs, PIP is for pill in the pocket, and VIP is for vial in the pocket. At the end of this presentation, I have 2 slides for a more interactive session, and I would request all the audience to point their mobile camera to the QR code on the display slide. So spontaneous termination of paroxysmal AF commonly occurs within the first 24 to 48 hours. By definition, it persists up to 7 days. About 50% to 75% will convert within the first day and approximately 60% by 2 hours. Yet, early termination of atrial fibrillation is desirable in a symptomatic patient. The PIP-VIP approach is best suitable for hemodynamically stable paroxysmal atrial fibrillation and in the absence of a structural heart disease. Although the use of vernaculant can be extended to mild forms of coronary artery disease, heart failure, and left ventricular hypertrophy. A PIP is a patient-first approach to minimize the drug burden by avoiding daily consumption of the antiarrhythmic drug, reduce medication costs, and also minimize the risk of adverse effects. It also empowers the patient to self-manage the episodes of sustained AF, thereby reducing the need to visit the emergency or be hospitalized. A VIP approach can shorten the stay duration of the patient. The first antiarrhythmic drug used for PIP therapy was quinidine. However, systematic studies for evaluation of quinidine as a PIP are required. Ibutalide and dofetilide are the most efficacious amongst the many antiarrhythmic drugs which can be used for chemical cardioversion of atrial fibrillation. Let's not get confused, but at 24 hours, amiodarone is the most efficacious antiarrhythmic drug in converting AF to sinus rhythm. But the PIP and VIP approach is based on achieving a rapid conversion to sinus rhythm at the earliest. Both flecainide and propafenone are class 1C drugs and are available in oral and intravenous forms. IV flecainide has a more rapid onset of action compared to oral flecainide, but both are equally efficacious. Vernaculant and ibutalide are used intravenously. Some off-label use of other drugs like ranolazine has also been used and has been found to be effective. The patient who is a reasonable candidate for this PIP-VIP therapy should meet each of the following conditions. Many of these conditions have been employed in some of the published trials describing PIP administration. The symptom onset should be recognized with reasonable accuracy and the episode should be acute. Home monitoring devices, which are becoming compact day by day, are also available to help the learned patient in the diagnosis of the clinical episode. The efficacy of PIP is inversely related to the AF duration. It is most effective on the first day and is far less likely to work for episodes longer than 7 days. Inherently, the patient should be on oral anticoagulation if he or she meets the CHA2DS2-VASc score. In the absence of chronic anticoagulation, there are guidelines for new onset atrial fibrillation which should be followed. Although the AF episodes are well tolerated, the first dose is administered always under close monitoring. Then the patient should be free of contraindications for class 1C drugs, which we will discuss later. The recommended doses for each of these antiarrhythmic drugs are based on the patient's weight. In individuals weighing more than 70 kg, flecainide is given in the dose of 300 milligram. And in individuals less than 70 kg, it is administered as 200 milligram. For propafenone, 600 milligram is administered in individuals weighing more than 70 kg, and in less than 70 kg, 450 milligram is administered. A rate control agent like calcium channel blockers or beta blockers is given prior to administration of class 1C drugs. Ibutalide is only available for intravenous use. The drug is not used orally due to its extensive first pass metabolism. In individuals less than 60 kg, 0.01 milligram per kg of ibutalide is infused over 10 minutes. And in individuals weighing more than 60 kg, 1 milligram is infused over 10 minutes. The second infusion of the same dose over 10 minutes can be repeated if the arrhythmia does not terminate within 10 minutes. Concurrent administration of intravenous magnesium along with ibutalide is recommended. Then current guidelines recommend that the choice of a specific drug should be based on the presence, type, and severity of underlying structural or functional cardiac disease. Flecainide and propafenone use is restricted in hearts without an abnormal structural substrate. Intravenous vernaculant may be administered in mild to moderate heart failure and stable ischemic heart disease. In a paper by the Bangalore group, Shantar et al. Concluded that with careful monitoring, ibutalide is clinically a useful option for pharmacological cardioversion of rheumatic atrial fibrillation. Also, in a separate paper by the Lucknow group, Anindya Ghosh et al. Concluded that flecainide is safe and effective for achieving and maintaining sinus rhythm in patients of rheumatic AF who are unlikely to have underlying coronary artery disease or ventricular dysfunction. Following antiarrhythmic drug administration in the PIP form, patients need to be monitored in the hospital for 6 to 8 hours for episodes of ventricular tachycardia, conversion to atrial flutter or tachycardia, or post-conversion pauses of bradycardia. Blood pressure monitoring every 30 minutes to monitor for drug-induced hypotension, and 12-lead ECG monitoring every 2 hours to monitor for drug toxicity, which manifests as 50% increase in QRS interval duration from baseline for class 1C drugs. The ECG effects of ibutilide are the same as seen with other class 3 antiarrhythmic drugs and include mild slowing of the sinus rate, QT prolongation. The PR and QRS interval remain unaffected. Then for pharmacological cardioversion of recent onset AF, the efficacy rates for flecainide were in the range of 52 to 92%, and for propafenone in the range of 56 to 83%. In other multiple reported studies, which included subjects exceeding more than 1,000 patients, post-dose conversion rates have been in the range of 55% at 3 to 4 hours and almost 80% at 8 hours. The time between the onset of atrial fibrillation and consumption of the pill is a major factor in these conversion rates. The median time from PIP antiarrhythmic drug administration to sinus rhythm restoration was in the range of 55 to 310 minutes. In other studies, this average consumption time was around 250 minutes. Then amongst the responders, which were around 28 to 50% of who respond to ibutilide, the arrhythmia usually terminates within 40 to 60 minutes of initiation of its infusion. Then a randomized study that compared propafenone, IV butilide, or rate control only in stable patients with post-operative AF showed that at 24 hours, no patients in the ibutilide group was in AF compared to 65% in the propafenone group and 34% in the rate control group. Amongst responders of ibutilide, the arrhythmia usually terminate in this study also terminated within 40 to 60 minutes of its initiation of its infusion. Vernaculant was found to be the most effective agent for pharmacologic cardioversion within 4 hours. Then the favorite drug of many emergency departments is amiodarone. Treating patients with a primary diagnosis of atrial fibrillation leads to increased expenditure with cost of hospitalization per patient running into thousands. In the United States, this cost was estimated to be higher amongst patients with paroxysmal atrial fibrillation. It is here where the out-of-hospital PIP antiarrhythmic drug approach has its greatest demonstrable impact. Specifically, the out-of-patient PIP treatment strategy results in a substantial reduction in ED emergency department as well as substantial reduction in the need for electrical or IV pharmacologic conversions.
कल मैंने कैंसिल कर दिया, मैं दूसरी जूम मीटिंग में हूँ, मैं 12 बजे आ जाऊंगा वहां पर ना, 10 बजे अपनी कैब लेके.
So the antiarrhythmic drugs are known to be arrhythmogenic and they may not be 100% efficacious. The onset of adverse effects were earliest for IV administered when compared to orally administered antiarrhythmic drugs. For ibutilide, majority of episodes of polymorphic VT occur within 10 minutes of the first dose of ibutilide, though they can occur even up to 4 hours or longer. And in a prominent study by Andrade group, similar previous studies on PIP approach, the adverse effects were in the range of 5 to 16%, and the failure rates were in the range of 17 to 42%. The onset of the adverse effects were in the range of 80 to 120 minutes after the consumption of the PIP. What are the adverse effects? Sinus bradyarrhythmias, pauses, rarely advanced AV conduction defects, and transient hypotension at the time of conversion have also been noted. These side effects were mostly seen in patients with possible pre-existing subclinical conduction system disease or those taking beta blockers or had a chronic renal disease. Few patients experienced a conversion from atrial fibrillation to atrial flutter, necessitating cardioversion. For the ibutylite group, the incidence of a polymorphic VT is 4 to 8% in several studies. Those requiring DC shock were less than around 2%, and non-sustained monomorphic VT occurred in less than 4%. In a previously successful PIP-VIP therapy does not exclude further events in those patients with successful first dose administration. These adverse effects are similar and include treatment failure, conversion to atrial flutter, pre-syncope and syncope. In cases of failure with PIP and treatment, the option remains rate control and elective cardioversion. If pharmacological therapy is to be continued, then the transition to one of the alternate treatments is available. Transition to an alternate antiarrhythmic drug treatment to a daily dose of antiarrhythmic drug, or finally an ablation can be offered. Then in highly selective patients with symptomatic paroxysmal AF, a PIP antiarrhythmic drug treatment therapy is associated with significant reduction in healthcare utilization, emergency department visits, and cardioversion. The initiation of PIP treatment strategy is associated with a significant rate of treatment failure or adverse events, thus reinforcing the need for vigilant monitoring during the index in-hospital initiation. Most patients progress to regular antiarrhythmic drug therapy or an invasive ablation procedure. A previous successful PIP effect does not exclude further events in these patients, emphasizing the need for careful patient selection. It is important to recognize that these patients for an outpatient PIP, that these patients the turnout of such patients is less in the outpatient department. The anticoagulation during its use should be strictly followed based on the guidelines. This is an ECG showing the flecainide toxicity. It was shared by Dr. Parag Barwad. Flecainide toxicity is potentiated by concomitant administration of other drugs or underlying channelopathies, and it is rare. The non-cardiac manifestations are nausea, vomiting, seizures, blurring of vision. Then bradyarrhythmias and QRS widening result from slowing of conduction in the atrial and ventricular myocytes, as well as the His-Purkinje fibers in a dose-dependent fashion. Additionally, tachyarrhythmias, particularly ventricular tachycardia, frequently complicate. And the theory behind is proposed that a non-uniform conduction, slowing and prolonging the ventricular myocyte refractory period, leading to the development of reentrant circuits. So successful management can be extremely challenging given its high oral bioavailability and slow rate of elimination. Flecainide is not effectively dialyzed, likely because of its large volume of distribution. The mainstay of medical therapy has been the use of high-dose sodium bicarbonate to offset the cardiotoxic effects of the drug by inducing a high-dose sodium load along with serum alkalization. This therapy alone has been shown to rescue patients from life-threatening overdose. Then high-dose hypertonic sodium bicarbonate is the mainstay of medical therapy, and the dose is given in an aggressive manner around initial 50 to 100 milliequivalent bolus, and to maintain a pH of more than 7.5 and a serum sodium concentration of more than 150 milliequivalents per liter. And finally, a slide on emerging therapies. Both upregulation and downregulation of certain types of two-pore domain potassium channel in atrial cells could underlie the offset of atrial fibrillation or aid its perpetuation. Novel drugs against these two-pore potassium channels like TASC1 and KV1.5 have emerged as a promising drug targets. The next two slides have a QR code and they lead to an online poll. I would request everyone to participate. This is the first question. It's a 75-year-old female who presents to the emergency room at the afternoon with complaints of palpitations. Her palpitations started after her morning tea and she has no other associated complaints. An ECG done shows atrial fibrillation with a ventricular rate of 115 per minute. A ECG was done yesterday prior to a dental check, which shows normal sinus rhythm. A resting echo done shows normal chamber dimensions with good LV function. The next appropriate step would be a beta blocker followed by evaluation for coronary artery disease, a PIP approach with anticoagulation as per guidelines, a trans-esophageal echo followed by cardioversion, oral amiodarone and anticoagulation as per guidelines.
Samir, I think we are a little short
Okay,
on
sir.
time again.
I'll stop then.
Yeah, no, you can do this, but you can get it discussed also.
Okay, sir. So, sir, would you like to give your opinion on this? So
Vivek,
yes, sir.
yeah, let Vivek have the discussion.
Yes, sir.
Vivek, please.
Yeah, hi. So yes, actually, this whole thing about AF with first time AF occurrence in a patient like this, the most important thing to my mind is that if there is no acute cause for this AF, no reversible cause, the first thing trainees should remember is to look at the CHA2DS2-VASc score. That is the most important thing, and that subsequently will determine the most important aspect of AF, which we need to keep in mind, that is thromboembolic disease. Once we have that, then the next step about acute heart rate control really depends on symptoms and hemodynamic stability and patient preference. So there has been many studies which have shown that people with mild symptoms can easily be discharged back home on oral rate controlling drugs. Regarding the pill in the pocket approach, this cannot, yes, there is, it is a possibility in such a patient, but for the 75-year-old female, I would actually like to evaluate for CAD before I decide to give any kind of class 1C drug for this patient. So my choice in this patient would be beta blockers followed by evaluation for CAD. So can I make some comments, Dr. Ashish, if that's okay?
Yes, sure. I
Time?
think we can do that.
Yeah. So couple of points. First of all, about flecainide, because practically speaking, we don't have vernaculant here. We don't have IV flecainide. We have ibutylide vials available in India, but because of the low demand, very few people store it all the time, and that's why it becomes a problem asking it when the patient needs it. So flecainide is a very useful drug. I use it very frequently for both my atrial and ventricular arrhythmias. But at the same time, one has to remember few caveats which are very, very important, because this drug can kill also. And AF may or may not. Mostly it will not, but flecainide definitely has a potential, even though if it is small. If you don't mind, can I share one holter here, if it's okay, Dr. Ashish?
Yeah, sure. Please. Samir, you'll have to stop sharing your screen.
So this patient, normal coronaries, by the way, so no structural heart disease, of AF, recently consulted me. Somebody has put him on 200 mg twice a day of flecainide. And with 200 mg twice a day, his weight is about 60 kgs. So you saw the bradycardia, you look at the QRS duration, you look at the ugly northwest type of axis this person is having, and then these kind of things which happen. Now this is inviting for disaster. This is like, and I have known patients who have been killed because of flecainide. So it's very, very important that it has to be given in a very guarded manner for these patients. The other thing with flecainide obviously is, which I think Dr. Samir did mention, but I think it somehow got lost, was that it has to be given with the rate controlling agent. So either deltaism or beta blocker, because otherwise it sometimes can organize an AF into flutter, and then with rapid AV conduction, you can actually become very symptomatic. The third thing with flecainide is, and pretty much for all the antiarrhythmics where you are trying a rhythm control therapy. Sorry, my mouse is playing through on here. Yeah. So the all of them is that you have given flecainide to somebody as a PIP or as a chronic therapy, and it doesn't convert. People just forget, and the person keeps on taking flecainide. Even though the AF is going on, he keeps on taking flecainide. The flecainide is not working. That is again asking for disaster. So never ever do that. If a person is on flecainide, it's there for a purpose. If that purpose is not served, flecainide should be withdrawn. I personally don't like giving it in a range more than 300 mg per day. And that too after somebody has gone through the earlier smaller dosages. So yeah, so that part needs to be remembered. And the last point I would like to make is that amiodarone is pretty useful also because it has an AV nodal blocking effect. So that's why, you know, many of these people convert spontaneously, but the rate control with AF happens with amiodarone. So that is another point that needs to be remembered.
Sure. I had only two comments. One is this concept of use dependence and reverse use dependence. So drugs like propafenone and flecainide, class 1C drugs, have a use dependence. That is, they are more effective at higher rates, and therefore they are good to convert AF to sinus rhythm. One important thing while using flecainide, of course, in long term is, as Vivek nicely showed, was the QT widening. They tend to affect the sodium channel, and therefore the effect that is seen is QRS widening. Sorry, not QT widening, QRS widening. And this effect is amplified at higher rates. So for example, if you get atrial arrhythmia, you will see further widening. Or if you put a patient on flecainide on a stress test, you will see the widening of the QRS, and you can misinterpret as a VT. So this effect of higher effect of flecainide at faster rates is called as use dependence. Whereas sotalol has a reverse use dependence, which means that it acts better at slower heart rates. It prolongs the refractory period more at slower heart rates than at faster heart rates. And therefore, sotalol is not a great agent to convert AF to sinus rhythm. Somebody asked that question in the chat box, but it is a good agent to prevent sinus rhythm from going into AF. So it is good to prevent recurrences, but not for the acute conversion, as is the topic of this discussion. I appreciate the tentativeness of both of you, Samir and Vivek, regarding the use of this approach and cautioning about this. It's a difficult topic. There has been previously an attempt to give patient that kind of autonomy when atrioverters were thought to be going to come in clinical use. Fortunately or unfortunately, they never made it, because to shock the atrium, even 2 joule and 5 joule shocks were painful. And that time it was thought that if the patient has a long episode, he would recognize that by putting a but the shocks were painful and it never went ahead. So atrioverters never came much in clinical practice, but that's just out of interest. I think once again, time is the biggest factor. We have had interesting discussions. Let's move on to one more such by Dr. Saurabh Deshpande, and he's going to talk of QTs and how they can play trons. Saurabh, you can share your screen and get started. This is the last presentation.
Great presentation, Dr. Samir. It was very succinct and to the point.
Thank you.
Yes. I think he has to thank Dr. Shomu Bora, with whom he has spent a lot of time and learned a lot many things from him, I guess.
So,
Saurabh, you can start. Yeah. Saurabh, your slides are seen, but your voice is.
Good morning, sir. Good morning, everyone.
Yeah,
I
great.
hope I am audible.
Absolutely.
Yeah. At the outset, I want to thank IHRS and especially Ashish sir for giving me this opportunity to share this case with you all. I'll not take much of a time because I'm the last presenter today. So I'll get on with the case. So I'll just give you a brief background. She was a middle-aged female.
Saurabh, this is an informal meeting. So if the learning is on, it's always good to continue. So we can continue the program till 11:45 for sure, or
Right.
5 minutes plus and minus. Yeah.
Thank you so much. So she's a middle-aged female who had rheumatic heart disease with severe valvular abnormalities, as I've written here. She also had rheumatoid arthritis and she was on HCQS, that is hydroxychloroquine. She had atrial fibrillation with fast ventricular rate. She was put on amiodarone and it controlled the ventricular rate, but did not revert her to sinus rhythm. She had a history of recent admission for PND. Mostly the history and everything suggested that the AF with fast ventricular rate caused the admission. Subsequently, within a few days, she underwent valve replacement for her severe valve disease. And this was her ECG before the procedure, before the valve replacement. As we know that calculation of QT interval in the setting of atrial fibrillation or flutter is a difficult task. There have been multiple approaches, averaging 10 beats, averaging 3 beats, and we all know the practical difficulties, but more or less this looks like a normal QT-C. So she underwent aortic valve replacement, mitral valve replacement, both were metallic. She also underwent tricuspid annuloplasty because of the severe tricuspid regurgitation. And for atrial fibrillation, she was biatrial maze was done. So most of the times it is LA maze, but some of the surgeons still prefer biatrial maze. So these are the incisions. This is maze 4. So there have been 1, 2, 3, 4 variants of maze procedure. So whichever the surgeon is acquainted with, they generally undertake those procedures. And these are the incisions which are standard in most of the maze procedures. I'll not go into details of those incisions. So what happened is she was put on a temporary pacemaker, and as you can see, she was completely pacing dependent, which again tells you that we have caused some damage to her conduction system. But the more important part, which we can see in these ECGs, is the QTC has been prolonged. So if you see my slides, I have written the QTC, and in bracket there is B and B. So those are the corrections which we generally use in case whenever you have a broad complex and you have to calculate a QTC. So there have been multiple formulas for it. I've just put one slide just to give a practical approach that we do in a broad QRS ECG to calculate QTC. So there have been multiple formulas, as I said, Rotherham formula, Bogosian formula, JT index. But we don't tend to use all those things. We practically increase the cutoff, or we subtract the difference between the QRS before the IVCD and after the IVCD in case we have both the ECGs. JTC is not commonly used because it is slightly difficult and the normal values are not very much validated. But the commonly used formula is a Wang formula. It has been validated in a smaller study, but still a good study. And that is what I practically generally use in case of IVCD, especially for left bundle branch block. This I'm talking about for a native ECG. In a paced QRS, it is most commonly right bundle branch block in endocardial pacing at least. So we have Framingham and nomogram correction, and we have a Bogosian formula. So Bogosian formula can be used in either settings, and it is fairly easy to use, as I have written here, the corrected QT. So you have to mind the difference between QT and QTC. The QT means the value which we calculate from the ECG that has to be corrected first, and then we have to run that value through either of the established formula. Most commonly used is the Bazet formula if the heart rate is between 60 to 100. So that's what we use. We correct the QT and then put that value in the Bazet formula and get your corrected QT. So what happened is post-op day 1, patient developed seizures, and thankfully the monitor picked it up and printed this strip. So as you can see, this clearly indicates that there is a polymorphic PT going on, and it was cardioverted at that point of time, and pacing rate was increased to 110. She had mild hypokalemia and hypomagnesemia, which were corrected subsequently. The important part was she was put on the A-pace V-pace mode. So that was kept later on. Then it was changed to ventricular pacing mode, that is VVI mode later on. So then after some few episodes of that, I was involved with the case, and then subsequently she was changed to VVI, and then I had started on a beta blocker, that is generally I prefer propranolol, that is for the prolonged QT, and we increased the rate, kept it around 90-100, and subsequently her QT came down. But yes, she required a pacemaker. But the hot debate at that point of time was whether to put this patient on pacemaker or an ICD. So as we read about QT in general, long QT, even in the congenital forms, the role of ICD is it's there, but it is there only in the settings where you have witnessed cardiac arrest. But then also you should know the caveats of the procedure at that point of time before putting an ICD in a long QT case, let alone in an acquired setting. So role of ICD, in my opinion, was not there in this particular patient. Patient obviously required spacing because of the conduction system problem which has started, and we had observed her for almost 2 weeks by then. So that persisted. So we had to put a pacing lead inside, and we had to put the rate at a slightly higher level till the time the acquired form of the long QT settles. So this is what was done in the patient, and subsequently she was discharged. I have a follow-up of around 1.5 years, and she has not had any episode till now. So just a little bit about acquired long QT. It was diagnosed first, I think described first in 1990 as a terfenadine-induced TDP. But then quinidine syncope has been described as early as 1920, but it was later on then described and recognized was due to a polymorphic QT due to quinidine. This is one of the important slides which we should remember, that differences between a congenital and acquired long QT. Acquired is far more common. Many of the times it is under-recognized because these patients may not develop TDP every time. We may not think of it. TDP is far less common as compared to the QT prolongation, as I said, because the TDP may or may not happen in every case. Now this 500 QTC and increase by 60 are not a very hard and fast numbers, but there have been some studies which indicate that if you are monitoring a person for QT prolongation, the TDP risk increases when QT corrected more than 500 or rapidly increased by more than 60 milliseconds. Short cycle is very typical in acquired forms of long QT, and it can give rise to TDP. Unfortunately, I could not document that in my case because the monitor recorded the strip after the TDP started. And in this subset of patients, acquired subset of patients, pause-dependent TDP is far more common. There are two hypotheses. I will not go into details in the molecular level, but we should know that the traditional thinking was that the delayed rectifier channel, that is IKR, and the HERG site was the main culprit. But there have been studies now which indicate the PI3K, that is phosphatidylinositol 3 kinase, is one of the problems, one of the factors which can be inhibited, and it can lead to TDP. And the specific and most important thing in PI3K theory, that it is sympathetic tone dependent QT prolongation and TDP. So the more the sympathetic tone, and the higher the chance of TDP in these patients. This is important in post-op patients like the patient which was mine. We should also know the concept of repolarization reserve. So as this diagram clearly highlights, if you are in the first subset of patients, when most of the times, like there is some baseline risk associated with gender and genes, which we can't change. Then you are older, you get hypertension, you develop LVH, or you develop LVH because of some other reason, and yet then you have been given a drug which can prolong QT. If it crosses the threshold which is required, then you can develop TDP, provided you're not treated for it in time. Then there are multiple possibilities and multiple risk factors like this, which can add on to your baseline risk and give rise to TDP. So you all must have been aware of all these risk factors. The most common risk factors that we see are the ischemia or the electrolyte abnormalities. Rest of the things, many of the things are underdiagnosed, but they can be there. So we should rule them out whenever we don't find any other cause. There have been some studies. This study is not very big, but this is a published risk score in patient who have been admitted, and you think that patient is going to have a TDP. So we can put these numbers, calculate the score, and the high risk patients should be kept in ICU and kept under observation for a longer time, so that we should know that they will not develop TDP later on, which can be life threatening. The drugs which can cause QT prolongation, the list is very long and it is periodically updated, as I've given the site there. This particular list I have taken up from the AHA 2020 guidelines. And if you go through this list, many of these drugs we use very frequently, especially the antiarrhythmic drugs. And many of our patients are on antidepressants or antipsychotics, or they are put on antibiotics during the hospital stay. So we land up giving 1 or 2 QT prolonging drugs. So we should be wary of this risk whenever we are treating a patient, especially in post-operative setting where the risk can be higher. An important part which is generally not highlighted, that even in the patients who have acquired long QT, they may have underlying genetic mutation. And this is the score, it has been done by, the study was done in 2016. And what they found out was these were the predictors where you should look for underlying genetic mutation. So as I gave you the concept of repolarization reserve, the people who have higher genetic tendency to develop long QT should undergo evaluation if these 3 things are present. That if the patient is young, that is less than 40 years old, baseline QT-C is more than 440, or patient was symptomatic at the time the patient presented to you. So if any of these more than two are present, then we should evaluate the patient for genetic mutation, which can be underlying in that patient. As we all know the management, I'll just go through it. We have to obviously remove the offending agent. We have to correct the electrolytes. The magnesium actually acts on the calcium channels, and it does not actually decrease the QTC, but then it stabilizes the membrane and decreases the chances of TDP. We should avoid QT prolonging drugs. I should not say that. The important part is ranolazine, flecainide, and verapamil they may be we may think as mechanism wise, they may help us treat acquired long QT, but they also inhibit IKR, which is the channel which is responsible for the acquired long QT. So we should be wary of using these drugs in this setting. Temporary transvenous pacing with a faster rate of pacing is the thing which comes to our rescue in these patients more often than not. Mexiletine has been tried in a setting where you can't shock, or there is some problem is there. You can always give mexiletine to terminate TDP. There are very few case reports, but yes, you can use that. Beta blockers, as are used in the congenital forms of long QT, like nadolol, which is not available in India, but then we have to go to our safer option, propranolol. So this is essentially what I was talking about, the stop and avoid the drugs. Injection magnesium, which can stabilize the membrane, which is irritable at that point of time. And the important thing which comes to our rescue is the pacing at higher rate. Thank you.
So fantastic presentation, Dr. Saurabh. Can you go back to the slide with gene and the gene and the drug? Yeah. So yes. So yes. Next, the previous slide. No, I mean that. No. Just give. Yeah, this is the one. Yeah. So I would like each and every participant to print this slide in your mind, because essentially, if you have understood this slide, you have understood what is happening to these patients and what do you need to do for that. This is a beautiful slide, and it just tells you that it's a polygenic kind of a rather multifactorial contribution of different factors which come together to cause this kind of a thing. For example, in this patient, it could have been the post-operative stress with sympathetic over-excess with amiodarone on board. Amiodarone, by the way, on its own is very uncommonly supposed to cause TDP, although we all have encountered it in our clinical practice. And then the metabolic consequences. Can you just go to the slide on management now, the first one, which mentions the pharmacotherapy? Yeah. So the other two things very important I want people to remember is that during acute phases of stress of any kind, the myocardial potassium levels are not equilibrated to the blood levels. So you might think that 3.8 or 4 is normal potassium, but the potassium level in the heart, which is what matters, can still be low. So imperative, absolutely critical that you do it, and you also advise the colleagues who seek your help from intensive care or surgery to keep the potassium at least 4.5. The other point is magnesium. Again, people would give one shot of magnesium and then say we have given it and that's it. You need to, in some of them, these people in whom you have recurrent TDP, you need to give it almost every day, almost even twice a day. So don't be wary of giving magnesium to these patients. The third practical tip is places where you can't put a pacer on, or you don't have the facility of a pacer. The poor man's pacer is there for these people, and that is isoprenaline. So very carefully, you can give them isoprenaline, start maybe at 2 to 4 mics per minute, and that causes the atrial and ventricular rate to increase. And then that is also a good option if it can be carefully monitored. You don't want to have too much high heart rate. The fourth thing is that although it's not mentioned in the slide, sometimes I have found giving of xylocaine or phenytoin also to be a little bit useful. It also causes some reduction in the QTC interval. Overall, an excellent presentation of a very, very timely needed topic.
Thank you, sir.
Thanks, Vivek. So I just wanted to bring out this concept of there is a spatial heterogeneity in repolarization and a temporal heterogeneity in repolarization. So when you, for example, in a Holter, you see a QT altering beat to beat, or the QT being different at 6 o'clock in the morning and say 3 o'clock in the afternoon. That is a temporal heterogeneity in the repolarization, and this can become a source of causing EADs and DADs and give rise to the polymorphic VT or torsades. There is also something called as spatial heterogeneity in the repolarization. In a deceased heart, particularly with scar from a previous infarction or cardiomyopathy of some sort, the repolarization is different in different regions of the ventricle. And this creates again a chance of forming re-entry circuits. So this is another way in which the difference in the repolarization can increase the chance to develop ventricular arrhythmias. So these are some of the things that you should probably know. Kumar, you want to say something before we wind up?
No, I just wanted to again say that the presentations were very excellent. We have to commend the speakers for taking this thing. Specific to the QT thing, I think a practical small tip, because sometimes, in an ICU, especially, there are so many drugs, we are scratching our heads as to which might be prolonging or not prolonging the QT. So the useful site which you can refer to is called qtdrugs.org. So qtdrugs.org. You can, it's a ready reference. I think you do need to register on the site, but you can have a quick reference doubt as to whether a particular drug is known to cause a QT or not, and you can see if you're very useful in a patient on multiple drugs and you're thinking which might be the offending agent. Any other?
I think you lost Ashish.
Dr. Vivek, I think Dr. Ashish had to, yeah, I think he had to leave because he has another parallel. We are close to concluding. If any further comments from your side.
No,
Dr.
I
Vivek.
again must commend the speakers. Fantastic program, and I hope it was of use to lots of trainees I can see, who attended this. do remember the take-home messages Dr. Kumar also mentioned. Thank you so much.
Yeah, so once again, I commend all the speakers for taking the efforts. I think they have all done diligent work. And as
Thank you,
Dr.
sir.
Ashish said, only we are limited by time. Otherwise, we can go on for some more time also. They have done a very good job. So, and I thank all the participants for taking out time on a Sunday. I hope they all benefited. Thank you, Dr. Vivek, also for wonderful comments. So I think we can close the session now and reconvene next month for the next session. Again, a big commendation to Dr. Ashish Nabar for carrying on this wonderful initiative.
Thank
All
you,
right,
everyone.
Thank you,
Thank you.
and
Thank you.
yeah, have a good day.
Have a
Thank
good day.
you.